So a very good evening everyone. Hope all of you are doing really good. Hope I am audible and visible to all of you. A very good evening everyone. So welcome to this NEET PG 2024 Psychiatry recall session. And before this, let me give you an update for all those who are going to give the future exams they will be preparing. So Rapid Revision 6.0 is being launched, that is on 16th of August, and in this not just English, we also have English video lecture, so you can also enjoy the English video lectures. And again, these are some of the important features: 260 plus hours of videos, 2500 high yield MCQs, and concise notes are there. Now before starting, again, this is a disclaimer that in this video we're trying to get hold of the questions, the actual questions which were asked in the exam, and to make some sense of the paper. And the final questions will be uploaded on the PrepLadder app. Now let's start with the question. Before starting the question, let me come to the analysis. Now what I've got from the questions which we are able to gather, that when we see psychiatry, I see that the difficulty level was around moderate level. So moderate level of difficulty was there. So what do you guys think? What was your opinion? How was the psychiatry question, if I ask you per se? And also if we see, I've seen the question of both the morning and the evening sessions. So what I've seen is the evening session, the difficulty level was slightly more. And one or two questions also we could see that there were more questions in the evening session. So we'll talk about this. And also again, seeing the question, again the same thing which I also repeated in the INI-CET recall session. We could see that the questions were from the main videos and the rapid revision videos. Many questions will say direct, indirect questions were there from the videos and the notes. And again we'll discuss some topics. Some questions also were asked from the LRR videos. And again, very important, what we have seen is they are not repeating the questions. They are not asking you PYQs, but they are repeating previous year topics. So we'll try to see what all important topics they've touched upon. Also, when I saw the question, I could make out that there was there was a flavor of INI-CET also. A lot of questions which I could see, they had that INI-CET flavor in them, be it questions on therapy, be it question on paraphilia, one of the repeatedly asked question in INI-CET. And of course, when we see the previous year topics, questions on substance, again, this was again asked. Question on alcohol, opioid, cocaine, questions were asked. Again, questions on psychopharmacology again were also asked. So let us begin the first question. So what we'll do is we'll first start with the morning session question, and then subsequently we'll also discuss the evening session. And meanwhile, you can also let me know if there are any changes in the question. So let's see this first question. Have a look at this question. A 45-year-old female comes to the OPD with complaints of feeling tensed and having stomach upset with heartburn and diarrhea. She reports of these symptoms, they're present since many years. So I hope this was the question. And seeing the question, we can see that what is the diagnosis we are looking for. So they're talking about generalized anxiety disorder, very important. And in the question, it is further stated that she reports her family members usually feel tensed and nervous. Again, in the family members also, they are feeling, symptoms of anxiety are there. Which of the following symptom is likely seen in the patient? So what is the right answer in this question? Again, as you can see, we've been talking about GAD even in the main videos as well as in the LRR sessions. We've talked about this in rapid revision also. In generalized anxiety disorder, there is excessive anxiety. There is, persistent anxieties there, free floating anxiety, and excessive worries are also there, as you can see in this question. So the patient is having GAD, and also we know, again we have discussed this in the videos also, that in GAD, along with those symptoms, a lot of somatic or physical symptoms, restlessness, irritability, muscle tension, those symptoms are also seen. So when we come back to this question, please have a look at this question. So what is the right answer here? So what is the right answer here? As you can see, the options are ideas of reference, tingling of extremities, hallucination, neologism. So we're talking about anxiety disorder, neurotic disorder. Again, hallucination, neologism, they're more favoring psychosis. Again, this is not the answer. Again, ideas of reference is also not the right answer. The right answer here is tingling of extremities. So somatic symptoms may also be seen in GAD. I hope this was the question. Let me know if there is any change in this question. I hope this question you're able to mark. So again, they've asked, a question, not a direct question, but if you have to make the diagnosis first, and then you see what other symptom may be seen. Now coming to the next question, which of the following drugs is used for opioid maintenance? Again, please have a look at this question and let me know if this was the exact wording of the question. They're talking about opioid maintenance. Options are naltrexone, clonidine, buprenorphine, disulfiram. Let me know if there are any changes in the question language or in the options. So again, as we are discussing, substance is a very important topic, and in this question again, when we go back to the discussion, so when we talk about opioid treatment, the treatment of opioid, we do it in two phases. One is the detoxification phase. In the detoxification phase, as you know, we manage the withdrawal symptoms. Okay, bupropion was also there in the option. Okay, so sorry, we're saying that bupropion was also there in the option. Let us add that as well. So in the detoxification, when we are managing the withdrawal symptoms, we use drugs like methadone, we use drugs like buprenorphine, and also sometimes we can also manage symptomatically by using drugs like clonidine to manage the symptoms of withdrawal. Once this withdrawal phase is over, then we come to the maintenance phase. In the maintenance phase, now coming to the maintenance phase, if you can see, again we have talked about this in the main videos also. There is one strategy which we use, that is opioid substitution therapy. So what we are doing is we are substituting the illicit substance opioid which the person is using. We are replacing it, we are substituting it with the medically safe long-acting agonists such as methadone, buprenorphine. In fact, also in the notes also you will find this. We have talked about this, that in the management, one is opioid substitution therapy, and also one more strategy is we can also use opioid antagonist like naltrexone. So coming back to this question, we are talking about opioid maintenance. So naltrexone, clonidine, buprenorphine is one of the drugs. Was naltrexone in the option? Let me know. Some of the students, they were saying naltrexone was not in the option. Was this in the option? Okay, was this in the option? Naltrexone, let me know. Naltrexone, was that in the option? Okay. No naltrexone. Okay, naltrexone was not there. So then we have come to this answer, that is buprenorphine. So we can use drugs like methadone, buprenorphine as OST in the opioid substitution therapy. Okay, so the answer becomes buprenorphine. Again, I always say, remember, buprenorphine, rhymes with morphine. So you can remember buprenorphine, it's a partial opioid agonist. So buprenorphine is the answer. I hope this is clear to everyone, right? So this is the right answer of this question. Let's come to the next question. Again, as I am saying, again, INI-CET, they usually ask questions on paraphilia. So this is one very interesting question again. A 30-year-old male needs to be dressed in female lingerie and high heels to feel aroused and have intercourse with a female. He denies, very important, any attraction towards male. What is the likely diagnosis? So please see the options. Let me know if this was the answer, this was the question. And let's see the options: gender dysphoria, transvestic fetishism, homosexuality, testicular feminization. So these were the options. Okay, I hope it is clear the question. So what is the right answer here? Again, the person gets sexually aroused by wearing clothes of the opposite gender. So what are we dealing with? This is again an important topic Paraphilia. Paraphilia, again questions have been asked. Okay, so it was gay mentality, you are saying. Okay, there was a gay mentality in the option was there. Okay, again this is being ruled out. They're saying that he denies any attraction towards male, so that is this option again we have ruled out. Gender dysphoria, again we know here the person wants to live like the opposite gender. He wants to live and be basically he wants to live like the opposite gender. So gender dysphoria is not there. So what is the right answer? The right answer here is transvestic fetishism. Again we have talked about this transvestic fetishism, also previously known as this is the previous name, now it is known as transvestism, eonism. Here the person gets sexual arousal by wearing clothes of the opposite gender. I hope this question is clear to everyone. How to differentiate gender dysphoria? The person wants to be accepted as a person of the opposite gender. Here there is no sexual arousal. Okay, here the answer is transvestic fetishism. Trans means opposite, vestism you can remember clothes, so getting sexually aroused wearing clothes of opposite gender. I hope this is clear, no doubt in this question, right? Now coming to the next question, have a look at this question. Now this is an interesting question. Please see this question first and let me know if this was the exact wordings, and these were the options. Which of the following selective norepinephrine reuptake inhibitor is used in ADHD? Again very important. In fact, a question on ADHD management was asked this year in FMG exam, and again a question on the treatment of ADHD is asked in NEET PG. Again we are saying that a lot of topics get asked in same topics in different exams. Was this the same question? Please remember. So what is the right answer? So again we have talked about this in LRR also, we discussed this. This is important. ADHD, we have, when we talk about ADHD, we have management stimulants usually are the first line treatment, and we know the drug of choice is methylphenidate. So please remember methylphenidate when we talk about, or amphetamine when we talk about, they are affecting both norepinephrine as well as dopamine. Please remember this. So methylphenidate, in fact, it inhibits reuptake of both norepinephrine as well as dopamine, and also amphetamine. Also again if you see the main videos, the notes, you will see dopamine is an important neurotransmitter which is being affected by these drugs. Modafinil, we know it's an alpha 1 agonist. Right, now coming to the non-stimulants, atomoxetine. Atomoxetine is one of the drugs which is norepinephrine reuptake inhibitor. This is one of the NRIs which is used. Then clonidine, also we know clonidine, guanfacine, these are alpha 2 agonist. Right, yes, clonidine was not there in the option. I'm just talking about the drugs which we know. Bupropion, we know again it's an NDRI. It also acts not just on dopamine but also on norepinephrine. Now please see this question again. So this is the question. So the question is, sometimes, again we have to get to the answer by ruling out other options. So reboxetine, is a drug which is not approved by the FDA. In some European countries it is used. Reboxetine is a norepinephrine reuptake inhibitor. Okay, when you say SNRI, some students are getting confused. SNRI here it is selective. There is something known as serotonin norepinephrine reuptake inhibitor. Don't confuse it with those drugs. Those are venlafaxine, desvenlafaxine. Please remember here, particularly working only on norepinephrine. Reboxetine is that drug in this question. I hope this is clear. Atomoxetine is not in the option. Yes, most of the students have said yes, atomoxetine was not there in the option. Had it been atomoxetine, that would have been, you could have answered it correctly. But still, if you see, you have to rule out, the other options. So the answer here is reboxetine. It is reboxetine. So I hope this is clear. Again, all the controversies regarding this question, I hope this is clear. Here, when we say, here it is selective norepinephrine reuptake inhibitor. Right, I hope this is clear to everyone. Right, sometimes we have to come to the answers like this, but again we have talked about this, that ADHD management is very important, and again twice this year question has come from the ADHD management. Okay, I hope it is clear. Right, great. Now let's come to the next question. Again, alcohol is one topic which they have been asking again and again, and again this time also questions, I think on both the shifts the question came on alcohol. A person chronically consumes alcohol, indulged in binge drinking 10 days back, was brought to the emergency in an unconscious state. Non-contrast CT scan shows it is normal. So maybe his blood sugar, although they're saying that it is 45 milligram per deciliter, so there is no CNS cause they have ruled out, and they're saying the glucose levels, hypoglycemia is there. And now you have to give dextrose to the patient, you have to treat the patient, you have to give fluids. Which of the following will you give? Again, very important. Can you tell me what is the right answer? Options are normal saline, IM, thiamine, followed by dextrose, 5% dextrose with vitamin K, 25% dextrose. These were the options I could gather from the students. Please have a look at the question as well as the options. I've been talking about this whenever we are managing a patient with alcohol. Very good. Yes, very good. The right answer here is you have to give, followed by, or you can mix with thiamine. We have discussed this again when we talked about this in the main videos, also in our discussions also. Wernicke's encephalopathy can be precipitated in such patient if you just give dextrose. So thiamine needs to be given. So again, we have talked about this even in our discussions, and even in the main videos, in the notes also we have talked about this, that it is again always a good practice to give thiamine in glucose. This is again something which we have talked about, and we want to prevent the precipitation of Wernicke's encephalopathy, because these patients may have deficiency of thiamine, and if you give dextrose, the patient may develop Wernicke's encephalopathy. So sometimes in emergency, if you give only dextrose, patient may gain consciousness, the person may appear confused, so there are symptoms of Goa. So many times in emergency, you will see this thiamine is usually mixed. So very, very important practical thing. So again, if you see, they're talking about a lot of practical aspects of management. Very, very important. I hope this is clear to everyone. Very good. It will worsen, it will precipitate, may precipitate Wernicke's encephalopathy. Okay, so we have talked about this even in the videos. We have talked about this, that we give thiamine along with glucose. So it's very important. Remember this very practical aspect of the question was there. Now let's come to the next question. Again, they've asked questions on antidepressant. A patient having on SSRI sertraline. Please see this question first. Let me know if this is the question which was asked. And amitriptyline was also added, and he developed serotonin toxicity, or serotonin syndrome. Let me know if these were the wordings, or were there any changes? Okay, were there any changes? Yes. So let me know if these were the wordings. Was serotonin toxicity or serotonin syndrome was mentioned, or symptoms were mentioned? One thing I want to know. So they are trying to say that along with SSRIs, we are combining amitriptyline, TCAs are also given. Yes, symptoms were there. Dr. Prashant, symptoms were there, or were there just talking about, they've mentioned it, serotonin toxicity was mentioned. Now again, I'll talk about this. So what is the right answer here? So we have been asked the treatment of serotonin toxicity, serotonin syndrome. So sometimes when we combine drugs which increase serotonin, sometimes serotonin levels may become very excessive. That is known as serotonin syndrome. Yes. So you're saying naltrexone was also there in the options. Okay. So let me add naltrexone. Thank you. So let us have the options which were mentioned in the question, so that when we put the final question, we are able to be as close as possible which was asked in the exam. Okay. No, symptoms were not mentioned. Okay, so it was only mentioned. So the question then becomes again fairly simple. We have talked about this again in the video, serotonin syndrome. When SSRIs, they're combined usually with drugs like MAO inhibitors, but of course they can also occur with other drugs which also increase the serotonin levels. Again, one should know some of the important symptoms like diarrhea, patient developing diarrhea. Again, in CNS, symptoms like myoclonus, hyperthermia, seizures, hyperreflexia. Again, these are suggesting towards serotonin syndrome, serotonin toxicity is there. And what is the management? Again, we have talked about this also in our videos, that cyproheptadine, supportive care, again can be symptomatic care, and cyproheptadine may also be used. So the answer becomes again easy. So if these are the options, what is the right answer? The answer is cyproheptadine. I hope this is clear to everyone. Okay. Yes, we discussed that question. It was we discussed it as the first question. When you can see that question again. We have talked about this. That was the first question. Neologism. That was again is more suggestive of psychosis. There the patient was having GAD. Okay. Let's come back to this. So now we are shifting towards the evening questions. Now please have a look. Let me know if any question in the morning shift has missed. Please let me know if any questions we have missed. Now see this question. Personality disorder again is one of the topics which they sometimes ask questions, especially on borderline personality. This time again, see the question. A 24-year-old male presents for evaluation. He appears very calm and charming. He behaves well in front of the psychiatrist. He's behaving well in front of the psychiatrist. However, he often gets into fights with friends, bunk classes, break traffic rules. Can you see a lot of behavioral problems in this patient? Also, multiple police cases. Somebody mentioned interrogation word was there. What is the likely diagnosis? Okay, I hope this is clear. This was the question. What is the right answer? So they are asking you. So there is a a pattern of behavior is present in this patient. So we're talking about, options are telling you that we're talking about a personality disorder. In narcissistic personality disorder, the person thinks himself he is more superior. Here such behavior, such violent behavior, violation of rights of others, those are not seen generally. Narcissistic personality. Paranoid, the person is suspicious. Schizotypal, again there is odd pattern of thinking, odd behaviors are there. The answer here is antisocial personality disorder. I hope you're able to get the answer correctly. The answer is antisocial personality disorder. Again, we've talked about this. There is does not give regards for the rights of others, gets into fights, violates the rights, get into unlawful activities, theft, lying, conning, is irritable, aggressiveness may be there, physical assaults, fights may be there. And many times we see these patients may be charming, especially towards the opposite gender. They are sometimes very manipulative. So this is antisocial personality disorder. And in antisocial personality disorder, again also we've talked about the management. Also, when you see the notes, generally therapy, psychotherapy is the mainstay of treatment in this disorder. Yes, these patients sometimes they are very charming, very manipulative, especially for the opposite gender. That is there. Narcissistic will not be charming. They want they say that they are more superior, they think themselves to be more superior. And antisocial, these patients may be charming, manipulative as well. So these are important clues when they're saying these symptoms, that is suggesting towards antisocial. Antisocial, again as I say, see the name, against the society, antisocial. Okay, so the answer is antisocial personality disorder. I hope this is clear to everyone. Okay, I hope this is clear to everyone, right? Now coming to the next question, again see this question. Again an interesting question again. So slightly a more trickier question were there, this again is an tricky question. Please see this question. Let's try to understand the question first. A 40-year-old female has visited multiple plastic surgeons requesting them correction of face deformity, and subsequently she was referred to psychiatrist. Why is she referred to psychiatrist? The patient repeatedly checks her face, insists that her face is deformed and needs surgery despite no evidence on examination. So this is the clue. The patient persists with a demand despite reassurances by the family members and the doctors, but still the patient thinks that there is some abnormality, some defect in her appearance, right? So see this. What is, first tell me the diagnosis. What is the diagnosis here? When we talked about obsessive compulsive and related disorder, that is one topic. Again and again, they're asking questions. Sometimes they ask question on trichotillomania, sometimes on hoarding disorder. This time they ask question, what is the right diagnosis? First, can you tell me the diagnosis? Yes, it is body dysmorphic disorder. Very good. Answer, the diagnosis is body dysmorphic disorder. It's a disorder we read in obsessive compulsive and related disorders. Of course, will not allow for surgery because there is a psychiatric illness. There is no as such defect in her appearance. So what is the management here? So what is the right management? Again, please remember, in conversion disorder, the patient has neurological symptoms. Here the patient is having preoccupations, thoughts that there is something abnormal in her appearance. So the answer is body dysmorphic. Again I always say, remember things from the name. Dys means abnormal, morphic means morphology. Okay, now see this. So this is what we have discussed in the videos as well. We've talked about this preoccupation with perceived defects or flaws in the appearance. Sometimes patient may also indulges in certain behaviors. We have also talked about this, like checking in the mirror, like comparing themselves with others, like this patient is doing. And also we've talked about this also, these patients may seek plastic surgeons for correction of their perceived defects. So all these things they have mentioned in the question. Now coming to the treatment, when we've talked about treatment, we can use SSRIs, and we can use CBT. Again, we've talked about this. So first of all, I want you to tell me, I hope this is clear. See the options, again, just see the option and tell me, were these the options? Were these the options? Psychotherapy was given. Now this becomes now interesting. Psychotherapy was given. Was a psychotherapy given in the option, or was it behavior therapy? If behavior therapy was given, then that would, because you please remember, the psychotherapy which we are using is CBT, cognitive behavior therapy. So we are using not just behavior therapy, we are also using cognitive techniques, because there are preoccupations, there are abnormalities in the thinking. So we are also targeting cognitive techniques. So behavior therapy would not be the right answer. Psychotherapy was given. Insight in oriented, I think, was mentioned in another question. Yes, CBT was given. Again, if psychotherapy is given again, so this becomes slightly trickier to answer. If only psychotherapy was given, we may go with the SSRIs. Again, they don't mention that which one is the preferred drug, but sometimes yes, in these cases, usually we may start with cognitive behavior therapy, and then we may also use drugs like SSRI. So SSRI is one of the drugs which is the first line drugs. So yes, studies have shown this is the first line drugs. If we talk about just drugs, if you ask me what is the drug of choice, I would go for SSRI. And if you ask therapy of choice, I would have gone for CBT. Specifically, I would have gone for CBT. So still, if you have to mark again, if CBT was not mentioned in the question, again we can go with SSRI. Again, I understand this is slightly trickier question which they've asked, but since they've asked specifically, they've given SSRI and CBT is not mentioned, it is just psychotherapy, then we may still go with SSRI, because SSRI is one of the first line drugs. If you talk about drugs, they are used in management of BDD. Okay. If only psychotherapy, then I would prefer SSRI. I would go with SSRI. Specifically, they would have mentioned CBT, then the question might have become a bit more trickier. Okay. I hope this is clear. Again, sometimes we see the patient, sometimes if therapy, the patient is reluctant to use, there are other symptoms, therapy is not, cannot be used, then we can start with SSRI. Okay. And usually in practice, we can use both. Sometimes, when we start with drugs, and gradually, when we're tapering drugs, we can also add, CBT. So out of the options, SSRI becomes a better answer. I hope this is clear to everyone. I hope this is clear. Sometimes there is something known as, delusional dysmorphophobia. There is a differential diagnosis. Again, we've talked about this even in the videos. Delusional dysmorphophobia. Okay. There is also a delusional dysmorphophobia. Okay. Some students are getting confused that, if patient is having delusional dysmorphophobia, then we can go with the atypical antipsychotic. Remember, the book says even in BDD, in which the patient is having the thoughts maybe up to a delusional level, in those patients also, please remember, SSRIs are preferred. So if you are comparing SSRIs and atypical antipsychotic, the answer still remains SSRI. So some students are having this doubt. So again, the answer remains SSRI. Even in BDD, in which the thought is up to a delusional level, then also SSRIs are favored. So I hope this is clear. So these are some controversies. Yes, I understand. Yes, Naimish, I understand. Yes, options were very tricky. I am there with you. I also am saying that yes, options are a bit very tricky question they had given, because first of all they've asked you to make the diagnosis, and then they've asked you to manage the patient. Okay, so the answer for this, if these are the options, the answer becomes SSRI. I hope this is clear to everyone, right? Now next question. Again, this such questions, give a flavor that, some INI-CET flavor is there in the question. INI-CET, they would ask more of prognosis, course, those things, therapies. Again, if you talk about this, again, I'll come to one more question on therapy. So a lot of topics of INI-CET also, when you see untreated ADHD persisting in childhood. So childhood, the person is having ADHD persisting in adolescence, increases the risk development of which of the following in adolescence. So tell me what is the right answer. Okay. Now, I think these drugs, when you talk about these drugs, I would not say these are pharma questions, because they're not just asking, about drugs. When you see in psychiatry, you would read about first line drug, which is the second drug, so again, yes, an integrated question, I would say. Yes, the right answer here is yes. So again, we've talked about this in our videos also, that 40% of the cases, they show remission in puberty or in early adolescent, first symptom to remit hyperactivity, last is inattention. We talked about this. Now some of the patients, they have remission, partial remission may be there, or they may have continuous symptoms. We've talked about this in adults, that antisocial personality disorder. So this was about adults we've discussed. Now here in the question specifically, they've talked about adolescence. So yes, so the answer here is in adolescence. Yes, it is conduct disorder. So there is increased risk of conduct disorder in those patients who have persistent symptoms in adolescence of ADHD. And in these patients also, there is an increased risk of substance use disorder also. Yes, the right answer here is conduct disorder. I hope this is clear to everyone. There is also increased risk of substance use disorder, and in adulthood, these patients have a higher risk. Again, we see that 60% of the patients, they may have persistent symptoms in adulthood. They may have developed antisocial personality disorder, substance use disorder, even mood disorders may develop in the future. There is an increase. So this is about adulthood. In adolescence, it is a conduct disorder. I hope this is clear to everyone. So the answer is B, that is conduct disorder. Now let's come to the next question. Again, this is again a question they are asking on therapy. If you see in INI-CET also this year, a question came on supportive psychotherapy. See this question. Let's first make a diagnosis. Again, a young girl presented with history of multiple episodes of loss of consciousness lasting for 20 minutes. These episodes occur only in front of family members and only in daytime, not in the night time. And also there is no history of tongue bite or incontinence. Imaging, and investigations, MRI studies, they are normal. First of all, see this question and let me know if this was the question and these were the options. Okay. Now in neologism, but a neologism is new words that is seen in psychotic disorder like schizophrenia. Okay. So what is the right? But insight oriented, I think, was mentioned in this question. Was insight oriented mentioned in the body dysmorphic disorder question? Let me know. We'll talk about aversive therapy. Here means we give noxious stimulus, painful stimulus. Again, this is not a very commonly routinely used therapy. For example, mild shock to the patient. Sometimes in substance use disorder, in paraphilia, sometimes even in other disorders, but not again you can see not very ethical. So not a commonly used therapy. For example, if in alcohol, we know there is a treatment known as disulfiram. We use drug disulfiram. That is a aversive agent. Patient develops unpleasant symptoms. So in aversive therapy, the therapy we are giving some noxious stimulus. Okay, options were the same. Question was the same. First of all, tell me what is the better please see this patient is having some neurological symptoms. Can you appreciate patient seems to have pseudo seizure? This is very important, but please don't confuse. In body dysmorphic disorder, patient has preoccupation that there is some defect. मेरी body में कुछ defect है appearance में. जब हम conversion disorder, when we talk about conversion disorder, patient is having neurological symptoms. Conversion disorder, in fact, we've talked about this. The new name of conversion disorder in DSM-5 is functional neurological symptom disorder. Patient is having neurological symptoms. These can be sensory, these can be motor. Like in this case, patient is not having true seizure. All these are hinting you that it occurs in front of family members. No tongue bite, no incontinence, everything is normal. It is telling you that patient has what? Patient has conversion disorder. These are pseudo seizures. And what is the treatment? Again, when we talked about this, so in LRR also we've touched about this. And conversion disorder, in fact, they've asked multiple times question on conversion disorder in INI-CET also recently in many of the questions which you'll see. So here they're asked question. We have talked about this, that examination, investigation, everything comes out to be normal. Patient may have sensory symptoms, motor symptoms. We have discussed pseudo seizure. Here the patient is having pseudo seizure, more common in females. So all these are hinting towards what? Towards conversion disorder. Again, we've talked about conversion disorder management also in the main videos, in the notes also. So we can use, psychotherapy is usually preferred. Psychotherapy is preferred, like behavior therapy. Behavior therapy, we manage on the current symptoms. Abreaction, where the unconscious memories, emotions, they are brought to awareness. Psychodynamic psychotherapy. Again, we try to use therapies like psychodynamic psychotherapies. Again, when we talk about pharmacotherapy, they have very limited role, usually just to manage some of the symptoms, like for anxiety, benzodiazepines, SSRIs for depressive symptoms, those can be used. Let's come back to this question. So here again, aversive therapy is not there. Valproate, again, drugs not have a very major role. Ketogenic diet, again. So here, insight oriented psychotherapy. In fact, if you see in the INI-CET question, they talked about supportive psychotherapy. There we talked about that in the psychoanalytic or psychodynamic psychotherapy, there is insight oriented psychotherapy. We try to bring, the suppressed conflicts, the unconscious mind having those conflicts, those we target. We go back to the childhood, any suppressed memories of childhood, all those things we see. Insight oriented psychotherapy is a better answer here. So therapy usually is used. So out of the option, if behavior therapy and insight oriented, then I would go with behavior therapy. Was behavior therapy also given beta here in this question? Okay, tell me if what were the options. If you can tell me, we'll again discuss this question. Let me know what were the options. Were these the options? If behavior therapy was mentioned, then I would go with behavior therapy. You are right. If you are saying behavior therapy was mentioned, I would go with behavior therapy. Yes. So if only behavior therapy, then you're right. Of course, it's a recall. I'm trying to get the question. It's okay. If, again, don't, see what is right, wrong. Just trying to figure out what is the question. If behavior therapy was mentioned, as we have just discussed, that would be the answer. Okay. Okay. I hope this is clear. I hope this is clear. If behavior therapy was mentioned, then we'll go with that. Right? Okay. Okay, so then again, if behavior therapy was mentioned, so still, so BDD वाला question का answer remains SSRI, ठीक है? And वहाँ पे behavior therapy था, हमने अगर वहाँ insight oriented भी होता, then also वहाँ पे SSRI था. यहाँ पे अगर behavior therapy option में, then that will be a better answer, ठीक है? I hope no confusion in this ना. हाँ, let's not see. हाँ, आप देखो option क्या था, then accordingly I will tell you what would be the right answer. हाँ, right, great. Let's come to the next question then. See this question. A patient brought to the hospital after road traffic accident, symptoms of confusion, irritability, tremors over there. He has history of consuming alcohol daily. Which of the drug is used to avoid the withdrawal symptom? I hope this is fairly, simple question was there. This was the question. These were the options. Let me know. So patient, seems to be having what? He's having alcohol withdrawal. Okay, he's having alcohol withdrawal, right? यही option था. Right, यही option था, right, and so the answer becomes yes. So you are correct. The answer is lorazepam. Again, this is straightforward question which they have asked. We've talked about this. Alcohol में हमने discuss किया, withdrawal symptom में tremors, delirium tremens में confusion हो सकता है, yes, and we've talked about this. Management में हमने discuss किया benzodiazepine, and benzodiazepine के साथ साथ thiamine also we add. Okay, but again if you have to choose one, then withdrawals के लिए we would go with lorazepam. Right, benzodiazepine. I hope this is clear to everyone. So alcohol, again, you see, they are asking again and again. Alcohol is one topic which they have been repeatedly asking. Now let's come to the next question. I think this is the last question we have. A mother reported that her daughter ingested a substance in an unknown dose, unknown form. Somebody have said was there in the option. Unknown dose or unknown form was there. And the girl, she presents with hypertension, tachycardia, mydriasis, hyperthermia. Can you appreciate this? Again, we've talked about this. Okay, we've talked about this. Can you tell me? So again, the patient is, intoxicated. There is substance intoxication. They've mentioned mydriasis, heroin, morphine. These are opioids. There we see meiosis. Hypertension, tachycardia, hyperthermia. These are suggesting it's a stimulant. So what is the right answer here? The right answer here is yes, it is cocaine. Very good. So we have talked about this even in the LRR session. We discussed cocaine is a short topic, but again and again they've been asking questions. It's a stimulant. So such symptoms are seen. Then another magnum bugs formication, that has also been asked. Then what are speedballs, nasal septal perforation, jet black pigmentation of the tongue? These can be seen with cocaine. Okay, so this was the right answer. So these were the questions which I could gather. Let me know if there are any other questions you can tell me. So these were more of the evening sessions in the end we have discussed. I hope the discussion was useful. Again, just relax. You've given exam finally. It is done and dusted. Use this time, do those things which you have been thinking of doing again and again. You've gone through a lot of changes, troubles during the exam conduction and all those things, but finally it is over. Okay, and enjoy your this time. Okay, and thank you very much for giving those options. Okay, and all the very best, and as I always say, keep smiling, keep moving forward. Okay, I hope this is clear. बेटा प्लीज रिमेंबर, अगर ADHD में उन्होंने ड्रग ऑफ चॉइस पूछा है, देखो क्वेश्चन क्या था उस पर डिपेंड करेगा आंसर. आई विल कम बैक टू दैट क्वेश्चन. ओके, so that is why I'm saying don't worry what the answer is being given. The question which we get, if you ask me drug of choice, beta I will go with methylphenidate. Okay, but I've told you now, अगर उन्होंने पूछा है selective norepinephrine reuptake inhibitor, बेटा अगर ये क्वेश्चन आया है, दे जस्ट टॉकिंग अबाउट नॉरएपिनेफ्रिन, तो बाकी हमने अभी डिस्कस किया ना कि बाकी में डोपामीन पे भी इफेक्ट है, मोडाफिनिल का अलग एक्शन है, अल्फा 1 एगोनिस्ट है, तो यहाँ पे फिर रिबॉक्सिटिन आएगा. देखो क्वेश्चन अगर पूछो ड्रग ऑफ चॉइस, तो आई विल ऑल्सो से इट इज मिथाइलफेनिडेट. ठीक है बेटा, देखो ये क्वेश्चन अभी हमने डिटेल में डिस्कस किया, तभी हमने जो क्वेश्चन आया था, अगर SNRI पूछा है जिसमें एस मतलब सेलेक्टिव नॉरएपिनेफ्रिन रीअपटेक इनहिबिटर है, आंसर इज रिबॉक्सिटिन, है ना. आई होप दिस इज क्लियर टू एवरीवन. ग्रेट. ठीक है, ये क्वेश्चन ड्रग ऑफ चॉइस पूछा है तो देन मिथाइलफेनिडेट, आई विल ऑल्सो से मिथाइलफेनिडेट. ठीक है, आई होप दिस इज क्लियर. राइट, ओके, सो थैंक यू वेरी मच अगेन.